Hello everyone. Today we'll discuss about cerebral palsy and its case presentation and the possible viva questions that can be asked in your practical exam. I'm just telling the model of how you'll present a case with cerebral palsy and possible viva questions. The exact questions may not be asked for you. Okay. So let us start. So for every case presentation, you'll be starting the case with age of the child. For example, 1.5 years old, male or a female child, name, coming from, brought by, and whose reliability is good. So this is the way you have to start every pediatric cases, whose reliability is good with the chief complaints of. So for a child with or when you get a case of cerebral palsy, you will be writing the chief complaints of delay in attaining age appropriate milestones. So delay in attaining age appropriate milestones from early infancy. This is from early infancy. Okay, once you can start the case like this, or the child will be a cerebral palsy child coming to you with the presenting complaints of convulsions or fever or aspiration. This can be the starting complaints also. Okay, if you start the case with a convulsion, writing a child with the abnormal neurological movements in the form of involving all four limbs, you have to write the type. So you have to start with the type of convulsions which is involving all the four limbs or any particular limb you have to write. Next is duration, how long it is lasting and how many episodes it has been occurred. Fourth, whether the child is on treatment, if the child is on treatment, and what is the duration of treatment. These are the questions you will be asking if the child is presenting to you with the complaints of seizure. Okay, supposing if you start with the chief complaints of delay in attaining the age appropriate milestone. Next, your viva questions can be, the possible viva question can be, what is development delay or global development delay? Definition. First is definition of global development delay. So when a child has a significant delay in more than or equal to two major domains, then you call it as the child is having a global development delay. So we will see definitions for each of the particular term in this definitions. Okay, so what you mean by a significant delay will be your next question. So the significant delay means more than -2 standard deviation for age appropriate milestone. Okay, this is the meaning of significant delay. Next, what is the major domains? So according to our IAP journal, so the major domains here are, and even in Nelson we have gross and fine motor. Second will be speech and language. Third will be cognition. Fourth will be social and personal. And fifth one will be activities of daily life. So these are the 5 major domains. If there is a significant reduction in the milestone, achieving the milestones of in any of the these 5, in any of these 5 milestones, you will be calling the child to have a global development delay. And this is the next question. Next, the third question or the second question can be your viva question. What is the severity, or how you will classify the severity of global development delay? This is classified based on your social quotient. So there are two, social quotient, another one is development quotient. Development quotient is nothing but developmental age divided by chronological age into 100. You call this as development quotient. Like same way you have social quotient. So here you will classify it as mild, moderate, severe and profound. Mild is when the child is between 55 to 70, moderate is between 36 to 54, severe is between 21 to 35 and profound is less than 20. So this is the severity of global development delay. This is your second question. So first is the definition of global development, next is severity of global development delay, and third one is points to note this know this child as cerebral palsy. So points to diagnose this child to have a cerebral palsy. Okay, first is delay in development milestone. Second, persistence of primitive reflex. So we'll take I'll take about the reflexes in a separate video. I'll cover reflexes, okay. Third is change in tone or deep tendon reflex. Fourth, and there is a presence of abnormal reflex. Fifth, absence of disease progression. This is the main criteria, that is absence of disease progression, because our cerebral palsy's main definition, main point is a non-progressive disorder. So absence of disease progression. So these are the points to tell that the child is having cerebral palsy. And next will be, what is the definition of cerebral palsy? Okay, for definition of cerebral palsy, you cannot change a word from the Nelson textbook. Okay, so this is nothing but a group of permanent disorder. As a group of permanent disorders of movement and posture that causes a activity limitation. So this causes activity limitation that are attributed to a non-progressive disturbance in the fetal or an infant brain. So that is attributed to a non-progressive disturbance. This is due to a non-progressive disturbance in fetal or in the infant brain. So this is the definition of cerebral palsy. So these are the possible initial questions that can be asked to you in your examination. Next, so when you have completed your chief complaints in a way like delay in attending the age appropriate milestone from the early infancy, next will be, I like to start from the antenatal period. You can go directly from that. So you can write, you can tell that you're going to start from the antenatal history. Okay. So next we'll go to the antenatal history. So what are the questions you will be asking here? First is age at marriage. Second is age at conception. Third, whether consanguineous marriage or non-consanguineous marriage. Fourth, pre-pregnancy weight. And fifth is weight gain during pregnancy. So from this, the other question that can be asked here is, when the mother's age is advanced, what are the effects that the infant or the fetus can face when the mother have an advanced age? What are the features that the infants or the fetus can face? The child can have, they can have a multiple birth. That is, the mother can have a twin child. Preterm delivery. That is an elderly, premi or elderly gravida. IUGR baby. You can expect chromosomal anomalies. Fifth, you can expect pregnancy associated complications like diabetes mellitus, pregnancy induced hypertension, hypothyroidism, seizures, and everything you can expect. So these are the things when the mother is a elderly gravida. Next question can be, what is the ideal weight gain during pregnancy? So this is one. This is second possible question. It is ideal weight gain during pregnancy. This ideal weight gain during pregnancy is classified according to BMI of the mother. BMI of pre-pregnancy weight. So ideal weight gain during the pregnancy is classified according to the BMI of the pre-pregnancy weight of the mother. So this is how you have to start the answer. When the mother's pre-pregnancy BMI, this one I'll write it here. When the pre-pregnancy's mother BMI is less than 18.5. So the weight gain can be, you can expect between 12.5 to 18 kgs. Or when the BMI is between 18.5 to 22.5. 24.5, that is normal BMI. So the weight gain you have to expect is between 11 to 15 kgs. When the mother is obese, more than 30, when the BMI is more than 30, the weight gain is 5 to 9 kgs. So these are the ideal weight gain during the pregnancy according to the mother's pre-pregnancy weight gain. Okay, so this question has been finished. Next you will be moving on to the first trimester history. So starting off with the first trimester. First you will start with the spontaneous conception. Second, pregnancy confirmed by urine pregnancy card test. Third will be mothers will be registered and immunized pregnancy. Fourth, you will be rating when the mother no history of fever with rash, usual histories, no history of fever with rash, radiation exposure, drug intake, excessive vomiting. Okay. Fifth, no history of bleeding or spotting per vaginum, no history of bleeding per vaginum. Mother has been taken iron and folic acid tablets regularly. So what are the possible questions from here? So it's a registered and immunized pregnancy. So what is the number of ANC visits? So according to WHO, how many visits should be there? Minimum how many visits should be there? So according to WHO, there should be at least minimum of 8 visits. This is according to WHO. Okay, fine. 8 visits. That is in first trimester 1. In second trimester there should be 2 visits. In third trimester there should be 5 visits. This is according to your WHO. According to Government of India, there should be minimum of 4 visits. This is your first possible question. Second, so you have told the history as fever with rash. For what you have asked this question? One is for torch infections. So when you tell the when you tell the answer as torch infection, next possible question from here is toxoplasmosis. First is T. It is toxoplasmosis. So what is the percentage of transmission of toxoplasmosis during the first trimester and the third trimester? So this is the transmission. So during the first trimester, the transmission of the toxoplasmosis rate is around 17%. You will remember it as 20%. While during the third trimester, it is 65%. So the transmission is more during the third trimester. And how about its severity? Severity is inversely proportional to it, because severity will be more when the transmission is during the first trimester and it is less when it is during the last or the third trimester. And what is the triad of toxoplasmosis? So triad of toxoplasmosis is chorioretinitis, hydrocephalus and cerebral calcification. Cerebral calcification, you can expect the calcification to be present in caudate lobe, basal ganglion and in the choroid plexus. So this is the triad of toxoplasmosis. Okay. Next, rubella R. So in rubella, what is the triad? So everybody knows the rubella triad is sensory neural hearing loss. Next is congenital cataract. Next is congenital heart disease. In congenital heart disease, you can expect the child to have PDA or pulmonary artery stenosis. Okay. So what is a distinctive feature of rubella? Next question is distinctive feature of rubella. So distinctive feature of rubella is its chronicity. Is its chronicity. This can be your next question. Okay. So this is about the rubella. This might be, this is more than enough when you know about the disease. Next is C for this one, cytomegalovirus. CMV. And CMV, what are the characteristics or most common symptoms or the features you can see when a child is having CMV is the child will be an IUGR baby. The child will have a hearing loss. This hearing loss will be a progressive hearing loss. It will be a progressive one. And another one is cerebral calcifications. Here the child will have a microcephaly, while in toxoplasmosis the child will have a hydrocephalus. Okay, this is the two main distinctive feature between CME and toxoplasmosis. So these are about the infection, that is fever with rash. Supposing if a mother is having a rubella, what is the other possible question you can ask in the first trimester? Another question you can ask here is this post-auricular lymphadenopathy. The mother can have a post-auricular painful lymphadenopathy. Okay, this can be the next question you can ask. Next, from this from the first trimester history, the other possible question is drug intake. So what are the teratogenic drugs? So you can just tell the examples of 2 to 3 drugs here. So next will be the drug history. So when the mother is on the drugs like phenobarbital, the child can have dysmorphic faces, mainly mid-face hypoplasia and hypocalcemia. First. Second one, if the mother is on phenytoin, the child will have the child can experience fetal hydantoin syndrome. So the child can features of dysmorphic faces, microcephaly, motor delay and mental retardation. Third, if the mother is on sodium valproate, the child can present with neural tube defect, motor incoordination and hearing disability. So these are the few examples you can tell. Phenobarbital, phenytoin, sodium valproate, warfarin. What are the other drugs? You can tell warfarin, lithium. So these are the possible question in your first trimester. Next will be this one, folic acid. So what is the dose of folic acid? For a normal mother with a normal pregnancy, your dosage of the folic acid will be 400 micrograms. Supposing if the previous pregnancy, the mother had experienced a neural tube defect child, or when the previous pregnancy is abortion or something like that, the mother have to take the dosage of 4 mg, that is 1000 times more than this. So normal pregnancy it is 400 micrograms, or for the previous history of neural tube defect it is 4 mg is the dosage of folic acid. This can be your next question. And the next possible is this excessive vomiting. So when the mother can experience this excessive vomiting? What is the possible relation between mother having a excessive vomiting and the child having a seizure? So when the mother is having excessive vomiting, mother might have taken a pyridoxine for a larger doses for longer duration. When the child has a seizure, or the child can develop pyridoxine dependency. So the child can have pyridoxine dependency. Okay, this can be another possible question. Next, this is about the first trimester. Next you will go for the second one. In second trimester, first one will be your quickening felt at 5th month. Second, no history of PAH, GDM, hypothyroidism, bleeding per vaginum. So these can be the other possible question. These are the questions you are going to ask in your second trimester. And you can also ask about quickening. We are asking about quickening felt, and whether there is a reduction of fetal movements, or whether mother have perceived any reduction of fetal movements. So what are the possible differential diagnoses when the mother has perceived a reduction in the fetal movements? One can be polyhydramnios. The most common physiological reduction in fetal movements is when the baby is sleeping. Another possible is when the mother had taken an antenatal steroid. So, but there is no definitive evidence for this, and there is no definitive reason for this, but they are told this as an additional point. This can be a reason for a reduction in the fetal movements. It is a physiological reduction. Pathological wise, when the child is a floppy infant, that is when the child has a motor neuron disease. Okay, when the child has a increase, or when the mother experiences a increased fetal movements, the possible reason is source. It can be a suggestive of intrauterine seizure. Okay, this is about the second trimester. Next is third trimester. In third trimester, you will be asking the history of blood transfusion. Second, again PAH, GDM, bleeding per vaginum, UTI, fever, foul smelling liquor. Because this foul smelling liquor, UTI, this everything can possibly lead to the child to have a neonatal sepsis. So you have to ask these questions. So this is about your antenatal period. Next is going on with the natal history. So going on with the natal history, we have to start with the place of delivery. Second, duration of the labor. Third, mode of delivery, whether labor natural or LSCS, or forceps delivery, or through vacuum. Fourth, whether the child was a term, preterm, or a post-term child. Birth weight, whether the child cried immediately after birth, liquor color, whether the liquor was meconium stained or not. Next is the Apgar scores. Okay, so here the possible question that you can have is duration, from the duration of labor. So what is the normal duration of labor, that is in the first stage and the second stage? So first stage of labor is classified as latent one and an active one. In latent, you have for both nulliparous women and multiparous women. In nulliparous women, the normal first stage of labor duration is less than 20 hours. In multiparous, it is less than 14 hours. In the active phase, it is 4 hours for nulliparous and 3 hours for multiparous women. And next, for second stage of labor, for nulliparous women it is 2 hours and for multiparous women it is 1 hour. If the mother is been undergone an epidural anesthesia, you have to add plus 1 hour. Okay. So I'll stop with this for today's session. Next I'll continue the postnatal development history, immunization and other possible histories in next video. Thank you. Please like, share and follow our YouTube channel for more videos. Let's all learn pediatric together.